Hello, this is Chris Ferrigno. In this video, we will be discussing the knee joint. Please note that this is the second of a three-part video series on the joints of the lower extremity. The knee joint is of particular interest for me and the focus of my research here in the Motion Analysis Lab. It is the largest synovial joint of the body. The knee is considered a hinge joint and participates mostly in flexion and extension. At first glance, this makes for a seemingly simple joint. However, it is anything but. It has a complex movement in both the frontal and transverse planes, while moving considerably in the sagittal plane. These rotational components help to unlock and lock the knee during gait. Because the knee is weight-bearing, it relies heavily on stabilization by four primary ligaments and fibrocartilage. It also relies heavily on the strength and coordinated action of the surrounding muscles and their tendons. At the knee joint, there are two separate articulations. The weight-bearing articulation occurs between the condyles of the femur, seen here, there are two of them, and the two condyles of the tibia, seen here, which help to form what's called the tibial plateau, onto which rests that distal femur. Like any other typical synovial joint, articular hyaline lines the surfaces of these condyles. The second articulation is between the patella and the femur and is known as the patellofemoral joint. Notice that the fibula is not part of the knee joint. The patella is the largest sesamoid bone in the body. What is a sesamoid bone, you might ask? Well, it is a bone that is suspended in a tendon, and it's named because it resembles a sesame seed. Functionally, the patella enhances the mechanical advantage of the pull of the quadriceps femoris muscle. The V-shaped intercondylar fossa on the anterior surface of the femur is the groove in which the patella glides during flexion and extension of the knee. The patella itself is oriented with its base superiorly and its apex inferiorly. The knee is a typical, very large synovial joint, complete with a joint cavity, articular or hyaline cartilage, and a capsule made up of a fibrous outer layer and an inner synovial membrane. The fibrous joint capsule attaches from the distal femur to the proximal tibia and is reinforced anteriorly by the quadriceps tendon, the patella, and the patellar ligament. The synovial membrane lines the entire joint cavity except for the areas occupied by articular cartilage, in which case the synovial membrane attaches to the periphery of the articular cartilage. Additionally, the cruciate ligaments, which are intracapsular, here we can see those cruciate ligaments in the middle, are covered on their surface by the synovial membrane. Although they are intracapsular, they are extrasynovial because they are outside the synovial membrane. Above the patella, the joint capsule extends superiorly deep to the quadriceps tendon as the suprapatellar pouch or bursa. It is anchored superiorly by the small articularis genu muscle that keeps the pouch from collapsing and locking up the knee, thus making it clinically noteworthy, particularly to orthopedic surgeons. There's an extensive network of bursa around the knee. Superficial prepatellar and infrapatellar bursa allow the skin to move freely over the patella during flexion and extension of the knee. A deeper infrapatellar bursa allows the patellar tendon to glide against the skin and at the underlying harder surfaces. The infrapatellar fat pad occupies deep space to the patellar ligament. It provides separation between the ligament and the bones. This fat pad can become enlarged or irritated, and it may contribute to patellar tracking issues. There are three significant extracapsular ligaments that surround the knee joint. Connecting the patella to the patellar tuberosity is the patellar ligament. This is the ligament that a clinician might strike to elicit a patellar tendon reflex. This allows the clinician to test the cord levels L2 through L4. There are also two collateral ligaments. The medial collateral ligament, seen here on the medial side, connects the medial distal femur to the relatively proximal medial tibia. If we spin this knee around, we can see the lateral collateral ligament connecting the lateral distal femur to the proximal fibula, also known as the fibular head. Looking back at the MCL, at roughly the midpoint of the ligament, its deep fibers are firmly attached to the medial meniscus. We can see that in this region here on the medial side of the tibia. Functionally, the MCL prevents excessive abduction of the knee. While the MCL is broad, because of these biomechanical loads sustained during functional tasks, the MCL is more vulnerable than the LCL. As such, the MCL is more commonly torn in contact sports, and because this MCL has this attachment to the medial meniscus, the meniscus tends to tear when the MCL tears. Conversely, the LCL, which is extending from this lateral femur to the fibular head, gets stretched when there is a varus force or a varus thrust at the knee. Relatively uncommon, this LCL is not frequently ruptured as a result, nor is the lateral meniscus, at least when compared to the frequency of the MCL and the medial meniscus. I'd like to introduce one muscle here within this lecture. Here we have the popliteus muscle. It's anchored to the medial proximal tibia posteriorly, and it extends upward and slips between the LCL and the lateral joint capsule to attach over here on the lateral femur. This muscle contracts, it pulls that way, and helps to spin the femur on a relatively stable tibia. Let's take a minute to discuss the intra-articular ligaments of the knee. The ACL, or anterior cruciate ligament, courses obliquely from the anterior intercondylar area, seen here, to the posterior aspect of the lateral condyle of the femur. The ACL helps to prevent anterior displacement of the tibia with respect to a stable femur. Conversely, the ACL also would help to prevent a posterior displacement of the femur with respect to a stable tibia. The ACL is the weaker of the two cruciate ligaments, in part because of a poor blood supply. Because of this weakness and because of the functional loads placed on the ACL, it is more commonly injured than the PCL. The PCL arises from the posterior tibia in this region. If we go up to this picture, you can sort of see the origin of that PCL. And it attaches to the medial condyle of the femur as it comes up in this area. Its function is the opposite of the ACL, so it prevents posterior displacement of the tibia with respect to a stable femur, or anterior displacement of the femur with respect to a stable tibia. During routine function, one can think of the PCL and ACL in this way. While walking, the PCL prevents the femur from slipping off of the tibia anteriorly, while the ACL prevents the femur from slipping off the proximal tibia posteriorly. So what are menisci? The meniscus of the knee is a crescent-shaped wedge of fibrocartilage that deepens the articular surface and serves as shock absorbers to dampen compressive loads or forces on the joint. In other words, these menisci increase the joint congruency, or the surface area connecting the distal femur to the proximal tibia. The menisci are thicker at the periphery, and at their external margins, they're attached to the joint capsule. The transverse ligament of the knee joins the anterior edges of the medial and lateral menisci. The menisci are also attached to the intercondylar areas of the tibia. The lateral meniscus is rounder and smaller than the C-shaped medial meniscus. Again, the medial meniscus is adhered to the medial collateral ligament, or MCL. As such, it is less mobile, less mobile than the lateral meniscus, which is nearly circular in appearance. The genicular anastomosis that surrounds the knee joint supplies the peripheral margins of the menisci with blood. This blood supply distribution is very important when considering the clinical ramifications of a meniscal tear. You can imagine that if you have a tear within the periphery of the meniscus in this region, it's much more apt to heal than if you have a tear on the inner parts of the meniscus, roughly in this area. In regards to meniscal tears, a bucket handle tear is the largest of all the meniscal tears. When you think of a bucket handle, you can envision the handle moving from one side of the bucket to the next. That's exactly what can happen. A sliver of this meniscus can flip over to lie in front of the femoral condyle, therefore causing obstruction. Another common meniscal tear is a radial tear that radiates outward towards the periphery. The intra-articular ligaments of the knee, particularly the ACL, are vulnerable to rupture. To test for the ACL, a common clinical test is to perform an anterior drawer test. In this test, the patient is supine with the knee bent to roughly 70 to 90 degrees. The clinician, stabilizing the foot not shown, will then draw forward relative to a fixed femur and test to see how much displacement of the tibia there is relative to the femur. The clinician should find some motion, but if the ACL is ruptured, they might get excessive motion and they will feel what's called a soft end feel, where the ACL is not becoming taut because there is no ACL to become taut. Conversely, to test for a PCL, the exact opposite is done at the tibia. The clinician pushes on the anterior aspect of the tibia and pushes the tibia posterior with respect to a fixed femur. Again, the clinician should see a little motion and should have a relatively firm end feel, suggesting that the PCL is lengthening and has lengthened completely and is catching. In the case of an absent PCL, there will be a very soft end feel. While the anterior drawer gives the clinician an idea if the ACL is ruptured, a more sensitive and specific test is what's called the Lachman's test. In this case, the knee is flexed to roughly 40 degrees. The clinician stabilizes with one hand on the distal thigh, i.e. femur, and then grabs the proximal tibia and gives an anterior glide on that tibia relative to the femur. Again, the clinician is feeling for the end feel, expecting some motion, but not excessive, and is feeling for that firm end feel when the ACL catches, thus preventing the tibia from sliding any further forward. The ACL commonly ruptures in sport, especially when cutting is involved. Unfortunately, I should know, having ruptured my ACL on 3 occasions. When the foot is in contact with the ground, the tibia tends to internally rotate and want to shift anteriorly. This is resisted, of course, by the ACL. During certain cutting maneuvers, these forces of internal rotation and anterior translation may exceed the tensile strength of the ACL, causing it to rupture. An unfortunate event sometimes occurs when this force is so great that even other structures are compromised. If internal rotation is accompanied by a valgus force, such as a hockey puck as shown here, the MCL can be excessively stressed. If a large valgus force occurs, like when an opposing player falls into the lateral knee, a huge stress causes an ACL and MCL to rupture, and the failing MCL pulls on and tears the medial meniscus sitting here. This is called the unhappy triad, and you can imagine why. So how is this injury reconstructed by the surgeon? Here, in the case of the ACL, there are generally three options. One, the surgeon can take the middle third of the patellar tendon and take this with a piece of bone here off the tibial tuberosity and another piece of bone off the patella and feed that through a newly made tunnel to reconstruct the ACL. Or they could take the semitendinosus tendon that sits here in the medial hamstrings, take that long tendon, fold it over itself a few times, and feed that through with a button anchor. Or they can take what's called an allograft, which is usually a patellar tendon from a cadaver, and they will make a new ACL out of that. Again, I've had one of each. I can't tell you which one I prefer. I prefer not to have any of them. The last two slides in this video on the knee will examine knee osteoarthritis, a form of degenerative joint disease. Osteoarthritis is a disease of the entire joint with loss of articular cartilage, the production of osteophytes, subchondral sclerosis or hardening of the bone underneath the hyaline cartilage, and synovitis. All of these lead to chronic joint swelling, chronic pain, and long-term disability. A large percentage of individuals will experience this disease during their latter years of life. The weight-bearing supporting joints such as the knee and hip, in addition to the CMC or the carpometacarpal joint of the thumb, are the most commonly affected joints. Insults such as an ACL tear, an unhappy triad, a meniscal tear, or even some occasional small trauma events can greatly predispose those to long-term damage and early joint disease. So here we see two plain film radiographs, one pre-op, one post-op from a total knee replacement. Realize the cartilage does not show up very well on X-ray. Therefore, in this radiograph on the left, this individual is suffering from degenerative joint disease in the form of osteoarthritis, specifically on the medial side. How do we know which side is medial? Well, here we have a fibular head, which is lateral, so we can assume that this is the medial side. Note the decreased joint space here. Absolutely no joint space here, while on this side the joint space is relatively preserved. Note the form of osteophytes, particularly here on the outside, and there are some labeled here on the inside as well. Note also that we see some subchondral sclerosis here, or whitening of the bone just underneath the presumed articular cartilage, hyaline cartilage, but probably very little to no cartilage left. Realize that this joint is probably very painful, although some radiographs look horrendous and the patient might be relatively asymptomatic. On the right side, we can see the tibial and femoral components of the total knee replacement. That concludes this discussion of the knee joint. As always, please let me know if there are any questions or if there are any technical difficulties that you may have had.